and then we'll do a good review at the end before we're ready to take the next test. I'm not going to talk about the test. Obviously, I've opened doors for you to come talk to me about it. We did get 2 questions back, so if you have any other questions about it, please let me know. By we, I mean me. So. It's like when 26% of the people in the class get the question right, it's probably not the class, right? So, all right. We're going to talk about pneumonia today. So pneumonia is a big topic. You will diagnose pneumonia. Some of these topics we talked about, you probably won't ever see it. But this one, you will definitely diagnose a pneumonia. You want to have it on your differential, especially in older populations. You want to make sure that this one pops into your head when you have patients coming in with respiratory complaints. Pneumonia is something that sometimes can present without a fever. Pneumonia is, a lot of people die from pneumonia. So we just had an actress die. Her name's Diane Keaton. I don't know if you know who she was. And she died of pneumonia. So it still has a very, very high mortality rate associated with it. Again, the very young and the very old are most susceptible to mortality. So very important topic. You will probably have questions on this. And again, you will see patients in clinical practice who are diagnosed with pneumonia. So we're going to go over it. We're going to talk about the different types of pneumonias, the different categories of pneumonias. There's about 8 different ways to categorize pneumonia. I'll teach you some of the more important ones, why it's important. We'll talk about the ones you acquire from the community versus the ones you acquire from healthcare settings. We'll talk about a specific category called aspiration pneumonia. Again, different types of bugs. We're going to be thinking different types of treatments. We'll talk about the flu and pertussis right at the end. All right, so again, pneumonia is a very common disease. It literally means lung disease. If you break down the word, pneumon means lungs. The suffix "ia" means disease in Greek. So it literally means lung disease. Lung disease can take many forms. In today's terms, we call it an inflammatory infection of the alveoli and the surrounding tissue. So right out of the gate, if I wanted you to correlate pneumonia with a clinical exam finding on auscultation, we've got stridor, wheezing, rhonchi, crackles. So this one's going to be, at least for the test questions, that'll be our exam finding that we associate with pneumonia. Does every patient with pneumonia have crackles on exam? Absolutely not. When we're talking about inflammation in the alveoli and mucus production, talk about those alveoli getting stuck and snapping open and shut, it sounds like Rice Krispies, a crackle sound. You can have unilateral, you can have bilateral pneumonia. Usually these are bacterial, viral, or fungal. We'll go through each one of those. We'll cover the bacterial today and one of the viral. And most people have, I've had pneumonia, you probably know people, or you've had pneumonia. Most people with normal immune systems recover fairly well. The problem is when we get into the age ranges, the very old, the very young, and people that have comorbidities, that mortality rate starts to spike. So this is FYI, this is just, again, this is like me showing you the 27 different guidelines we have for asthma. There's a lot of different ways to categorize this. Sometimes we categorize it by what caused it. Sometimes we categorize it by where it was acquired. Sometimes we'll say lobar versus interstitial. So there's a lot of different adjectives that we use to describe pneumonia. So you may see any combination of that. They're all important. They all are important clinically. They all tell you something differently about the etiology, about the prognosis, about where you need to care for them. So understanding those, when you hear them, what they mean. We're going to focus a lot on the top 2 today. So CAP. CAP is probably our most common pneumonia. This is an FYI slide. The intent of this slide is to teach you that the mortality is associated with old people. When we talk about evaluating people in terms of disposition, so when you diagnose someone with pneumonia, the next decision is whether or not you can treat them safely as an outpatient. One of the biggest things that we talk about is how old the patient is. So as patients get older, by sheer nature of being aged, they have a higher risk of dying from pneumonia. So this one's also just an FYI slide. This one shows the power of, well, I mean, I'm on one side of the fence for vaccinations, but I'm closer to the fence than I would have been maybe 20 years ago. But this Prevnar, we talked about epiglottitis and the most common cause being Haemophilus influenza B. Now that we vaccinate for it, our cases of epiglottitis have gone down significantly. Same thing with pneumonia. We started giving the Prevnar vaccine to children, to infants, and we've seen a significant decline in mortality in kids under 5 since we started doing that. So this one I don't have any conspiracy theory for. I think it's working. All right. So CAP. So the important part about CAP, very, very simple. Clinically, you reason that this person caught this pneumonia in the community. And what that correlates to is there's different types of bugs that are more common in the community than there are in other areas. For example, a nursing home or a hospital. So designating something community acquired means that you think they caught it in the community. In the grocery store, at work, somewhere outside of the hospital setting. So you either were outside of the healthcare setting around the time your symptoms started, or just before. You weren't in a nursing home at the time. You weren't in a hospital. We went over a ClinCourt case today, right? We talked about getting a good history, but when you're thinking pneumonia, it's just a little extra thing we need to make sure we're thinking about when you're evaluating someone for symptoms and you have pneumonia in your differential. Where were you when you caught it? One thing that gets a little tricky is someone that you're taking care of in the hospital, but their symptoms start within 48 hours of admission, then technically, and for the test, technically the assumption is that person actually caught the pneumonia before they were in the hospital. But getting that history is important. Where were you when the symptoms started and maybe 2 days prior? Trying to figure out, were they in a place where there's a lot of nasty, high resistance bugs, or were they just out in the community where then we need to be in touch with our community and what types of bugs are in our community? Because that also changes as well. That's why you make friends with infectious disease, so that you know what kind of things are in your community. And lots of most commons. So most common infectious cause of death in the U.S. Second most common cause of hospitalization. When you do inpatient, you will take care of a lot of people with pneumonia. It's very, very common. So we'll talk about bacterial. Why are the elderly at higher risk? And that has to do with their immune system. Their immune system is not as effective. So the normal things that happen in our body, bacteria in our body every day. Viruses enter our body every day. Intact immune systems are usually able to mitigate that, to fight it off. With the elderly, a lot of them have a poor cough reflex, ciliary functions decreased, their antibody response is a little bit down, so they just become more susceptible to that bacteria or that virus or that mycotic substance getting in their lungs and settling in without having their immune system clear. And then of course they also have multiple comorbidities. COPD. And something, when we talk about vaccines, we'll talk about that Prevnar. When we talk about influenza, this one will come into play as well. So vaccines don't necessarily decrease your chance of getting it. I know a lot of people, when they have the COVID vaccine, I heard a lot of people saying, oh, I got the vaccine and I still got it. That's not really the point of vaccines. It is to some extent, right? We create herd immunity, but more so it's to give your body a little exposure to it, so when you are exposed to the live virus, you either have enough antibodies to fight it off, or you've got sufficient that you're not in that high mortality category. It's not as severe. All right, community acquired, again, why people get sick. So something's going on in their body. When people have viruses in the winter, and they get sick, this is already going on in their bodies. So when you get sick, right, you want to use the hand sanitizer, you want to take care of yourself, you want to stay home, you're not feeling well, you don't want to expose yourself to a strep pneumo or a mycoplasma or something, because really you're already in this state. Your immune body response is already fighting off something else. Sometimes you just run into it very in the butt too. And then overwhelming inoculum. So it's not necessarily virulent, but you're sleeping in a barracks room 2 feet from somebody who is sick. So that's why when we talk about public health and things like that, you will be the public health officer for your unit. Those are things that we need to consider. Removing people, isolating them if they're ill, not letting them go into that area where they're just coughing up all their stuff 2 feet from the next person. Prevention, this is the goal. So some of the things we do to prevent the mortality and morbidity associated with pneumonia, death, and hospitals are filled up with pneumonia, so we can't, provide so much health care. That's a lot of that is getting people to be healthier in general and in vaccinated. All right. This is FYI, I don't expect you to memorize this. The big one here, and we'll talk about this one as being the most common, is our strep pneumo. It is the most common, such that we just developed a vaccine for it. So definitely the most common. So right main stem bronchi for foreign bodies in the lungs, and strep pneumo for community-acquired pneumonia. These are some other etiologies. So we'll start top left, obviously most common. It's in blue, it's exciting. H-flu up there, but more common in our COPD patients. Klebsiella, we'll talk about aspiration pneumonia. Very common in the alcoholic population by the sheer nature that a lot of them become incapacitated and vomit a lot. Other gram-negative rods. I think everybody's heard of all these. These two down here, the Staph aureus, the MRSA, and the Pseudomonas, this is where we differentiate community-acquired from nosocomial. So when you say it's not community-acquired, what you're saying in doctor terms is, I need to cover for MRSA and Pseudomonas. So that's essentially what it means. When we determine something is community-acquired, that is saying, unless you're in a really special population, that is saying that we probably don't need to cover for MRSA or Pseudomonas. On the right, we'll talk about flu A today, talk about pertussis. Then we've got these atypicals. I'll have a little slide on those as well. This is that walking pneumonia that people get, where they're upright, they're sick, they got this nasty cough. It's a little bit longer than it should be. Their chest x-ray is not really exciting. The chest x-ray is not really exciting. So they're sick, but maybe they have a fever, but it's very low. They're up and around and moving. They don't look like your typical 103.5 sats in the low 80s, but they still have a pneumonia. So most common bug there is going to be our mycoplasma. And then the other chlamydia, I don't know why. Every time I see chlamydia I'm like a child. It's the other chlamydia, not the track. And then anaerobes. We'll touch on those again when we talk about aspiration. Not good to get in the airway at all. All right. Obviously, symptoms depend on the patient. They depend on what's causing the pneumonia. If it's a bacteria versus a virus, different degrees. Most people will have a cough, but some might not. Fevers and chills. Classic in the elderly population. My mom was diagnosed with bilateral pneumonia with abscesses. Never spiked a fever. Like a really weird bug too, when I finally pulled it out. Never, now the cough, absolutely. The dyspnea, absolutely, but she never spiked a fever, so. Clinical suspicion needs to be there. Symptoms help you. There needs to be something that makes you get that chest x-ray, right? But it doesn't mean that they're not having a fever that they can't possibly have pneumonia. Chest wall pain, one of my fellow residents ended up being hospitalized with bilateral MRSA pneumonia. He thought he was sore from his PT test. This was back when we still did efficients. And he literally was like, man, I'm sore from that PT test. Looked like crap, but that's what he thought. And it ended up being bilateral MRSA. It was terrible, yeah. Chest wall pain, fatigue. Atypical, like we said, can be a lot milder. So not something we suspect. The last time I diagnosed atypical pneumonia, it was a bunch of AIT students in barracks. And it wasn't the individual patient, it was the number of patients coming in that I was like, man, are they all from the same barrack? And they all were, and they all had kind of like these, they didn't have lobular, consolidations in their lungs, but they were all just kind of hazy and a little scattered opacities and all that, just very nondescript. 99.1, 99.8, but it was the volume of people coming in that finally had maybe culture one of them. All right. Oh yeah, what's wrong with that picture? This stethoscope I think is not in your ears. That was one of them, but there's another thing that it was my pet peeve during, well, flu before we had COVID, but who should be wearing the mask? The patient. No. It was just always one of my pet peeves. Like the sick person's supposed to be wearing the mask. Unless I need PPE, then I should be wearing an N95. All right, so vital signs would make sense, depending on how severe it is. Obviously, a patient can have a normal heart rate and still have pneumonia, but when someone's fighting off a severe infection, especially in a major organ, there's going to be some tachycardia, heart rate will go up. Your body's working hard to fight off this infection in a major organ. So, there we go, there's our crackles. Remember this dullness to percussion, this fremitus, all these little sound changes we talk about, that means consolidation. So fluid, bacteria, and all the nasty stuff that goes with it, all the purulent material. So that could be something that you can come down and feel that change on that left side, or that right side, or wherever the pneumonia is. So labs don't play a huge role in this, thank God. CBC is definitely going to be helpful. So look for any white cell changes, especially neutrophilia, which suggests a bacterial infection. ABGs, if the patient is having respiratory issues or if they're desatted and they're in the ER, we want to know how severe they are. Do I need to put this person in the ICU? Do I need to put this person on the floor? That's where ABGs can be helpful. And sputum cultures, for community acquired, you're seeing outpatient, you do not have to get sputum cultures or blood cultures on patients. Typically, if you send them to the ER because of their symptoms, they're going to get them. Best time to get them is right before you start antibiotics, so they cook. No combo, right? There's nothing that's going to tell you this diagnostic is just get the chest x-ray. Have a reason to get the chest x-ray, but just get the chest x-ray. So most of them are going to be diagnosed on chest x-ray. Do not be afraid to get chest x-rays. There's my money sign again. So it won't tell you what type of pneumonia it is, but it'll give you a hint. So bacteria are focal, they aggregate, they form the pathology of how they cause disease in the lungs. It's very focal. They start attacking tissue locally. So in most cases, we're going to see something lobar. It'll be well defined and it'll be in one area. It grows out. Viral or atypical, they're more diffuse. There's not a focal place where all of that's growing out of. So sometimes we'll go in and there'll be a pneumonia. Patients can also, when we learned about pleural effusions in a few lectures, That can cause, so infection can cause the body, we'll go through that when we talk about pleural effusions, but basically the fluid leaks back into that pleural space, right? And it starts to fill up the cavity. And that usually suggests that pneumonia has been there for a while. It's had time to cause that change in the osmosis of the lungs. And if it's normal, completely normal, probably not pneumonia. Probably. So it's a good rule out in general. All right. Oh, ultrasound, useful. CT, not something you're going to order regularly in an outpatient clinic. But you will. We'll have, when we talk about pulmonary nodules and following up incidental pulmonary nodules, which is fun to do in primary care, because they're always getting CTs in the ER, and then patients come back and they're like, they found something. Not something that we would order in the outpatient setting necessarily. It's when we're looking for other stuff. All right, so if everybody can see that, fairly consolidated. It's funny, every time I look at a chest x-ray, I kind of have to be like I don't see things right away, and then they're obvious, right? So orient yourself. This chest cavity is nice and clear. Might be a little fluid in that one actually, because you lost that costophrenic angle. But here, CPR, left lower lobe. No, yeah, left lower lobe. There's no middle lobe over there. Such nerd jokes, I know. Should make a joke out of that. Nerd. Alright. This is FYI. So this was just someone's got a cough, shortness of breath, heart rate, very, very, very common presentation for pneumonia. These are just the other things we want to keep in mind. Acute bronchitis probably won't have a fever. They may have the probably less predominant dyspnea and tachypnea, right? Influenza can present very similarly. Asthma probably won't have the constitutional stuff. CHF will have other symptoms associated with it, plus a history of something cardiac. COPD will be our typical patient. Smoker, on inhalers, and then PE, we'll talk about that one coming up. That's more chest pain predominantly and shortness of breath. All right, so we saw our patient, we did our history, we sent him for a chest x-ray, and the chest x-ray was this, and we said, okay, sir, ma'am, you have pneumonia. And it is a community-acquired pneumonia because you have been at home, not in a healthcare setting, 2 days prior before your symptoms started. So yes, you have community-acquired pneumonia. So the first question you have to decide, we talked about the high mortality rate associated with pneumonia. So you need to decide if this patient is safe to treat as an outpatient. Remembering that we kill people in hospitals, which is a terrible thing to say out loud, but hospitals are not places to get well. They are places to stay alive. So if we need to provide potential emergency support for someone, we think this person's going downhill and they're going to tank, or they need interventions that we can't safely give at home, like IVs or other interventions, then we hospitalize them. So we're looking at risk versus risk, right? Risk of letting them be outpatient versus risk of putting them inpatient. Don't ever forget that sending people to the hospital is not without risk. Admitting them is not without risk. So we're going to use this thing called the curve 65. You will get this again when you do EMED. There are several, I'm going to show you all these different little calculation things that you can learn. I'm going to pick the easiest to make you memorize, because as long as you have that, I think you're ahead of the game, if you can remember that one. Also, I'm picking that first one because you don't need labs to score it. You just need a set of vitals and to know whether or not your patient, to have your patient to be able to do a mental status exam and obviously to know their age. So, in general, You want to consider hospitalization for these patients. You've got this patient sitting in front of you. They're a 72-year-old male who takes care of himself at home. He's got a ton of comorbidities. You can't get his SATs, above 92 without a liter of oxygen, which is never needed. So, Curve 65 is one tool, but you've also got to consider all the other things. Is this person going to need IV, right? Are they dehydrated? And then some social thoughts too. You got to think about that stuff. Where's the safest place for this person to get taken care of? Versus that same 71-year-old who lives with his daughter, who's a nurse, who takes full-time care of him, who is married to a respiratory tech, right? So, know your patients, make sure you consider that. All right. So here's the Curve 65. So it's very, very easy. Confusion, respiratory rate, blood pressure, 65. Confusion means you have to look at your patient and assess their mental status, right? Like, hey, good morning, what's your name? Like you have to actually it's an objective finding. You can put it in psych, you can put it in neuro on your objective, but you have to actually be like, I assess that. And then you'll get pretty good at assessing it. If you get a little weird feeling about it, like you just met the patient, is that their baseline, or are they, you can pull people in the room, people that know him, you can call people, you can actually do a full mini mental if you want, go through his record, but if the patient is confused, they get a point. Because if the patient is confused, that means that something's not getting oxygen to their brain as efficiently as it should. Respiratory rate, right? Greater than 30, greater than or equal to. Blood pressure, and this is a less than. Have you guys learned about sepsis yet? Sepsis? Something. Yeah. For shock. Yeah. Shock is when you're not perfusing enough blood. So blood pressure comes in there. Not too high, right? We're always worried about too high in cardiology. But this one we're worried about being too low. So if they're hypotensive, tachypnic, confused, or they're old, then they get a point. And of course, there's a gray area. There's a use your clinical judgment area. So if there's 0, you can safely say, pretty confidently, they're probably safe to go home. If they're group 3, which means they're tachypnic, they're hypotensive, they're a little confused, they're 70, probably need to hospitalize them. 1 or 2, just consider it. Now that one says likely need hospitalization. I don't think that, I wouldn't totally agree with that. So to me, it's still not a send them to the hospital. But consider it. At least consider things, right? This is not, if you have a person who is a 2, and it's that 70-year-old who has a daughter who's a RN, who's a full-time caregiver, right? Totally good social situation. They have a great PCM that's already called them and said they'll see him tomorrow, right? That's more important to me. People won't be like, well, his curve 65 was 2. So use your clinical judgment. But this is a tool. This is the PSI one, obviously much more accurate in predicting mortality, but look at all the crap you have to get. So this is not realistic in the outpatient setting unless you want to try to get an EEG in your clinic. But it's very useful, right? So a lot of times when we do admissions in the hospital, we'll calculate that. There'll be sections in the admission note on good EMRs where you put all that stuff in. This is another reason sometimes we'll get an ABG in the ER is to help establish this. So they go to the ICU or they go into the floor, right? I don't know if you guys, did they teach AOS, area under the curve, in research eval? Area under the curve? It's whatever. So what it means is you're capturing, the area under the curve is how well, so the area under the curve is like, so if you look at here, right, it's all this area in here. So there's most area under the curve for the red dots. So that means you're capturing the most cases. So you were right that many times. So much better area under the curve, much more specific, much more sensitive, right? Here's our nice specificity, sensitivity. So this PSI one obviously is much more sensitive, much more specific, requires a lot more work versus these two. But I don't know, I mean, getting that BUN in addition to not getting the BUN doesn't really give you that much more AOC, so knowing that curve 65, regardless of whether you're able to get that BUN, if you can get it, but statistically it's not going to give you that much more sensitivity and specificity. All right. So outpatient management, again with the antibiotics, I promise you I will let you know which ones I want you to memorize. Obviously antibiotics are the choice. If you know what the bug is, obviously treat as such. Minimum 5 days. We're going back to which antibiotics to use, kind of like we did with COPD, where you're looking at the patient characteristics to try to give you a better understanding of, you know, do we have to use different antibiotics? So, simple question, have you used antibiotics in the last 90 days? What were they? Are you over 65? Do you smoke? And do you have other major comorbidities? Unless they're allergic, if all these are negative, then you give them amoxicillin. I will tell you that within the last 3 semesters, I've updated this. So remember that lifelong learning thing? That's why I hate to test on antibiotics, because right now it's amoxicillin. I think it was like Levaquin for a while. And then if yes to any, so I doubt I'm going to ask you specific antibiotic questions on this one. I just want you to keep in mind that when you're talking about treating, that you always want to consider certain things before you make a decision on which antibiotic to choose. Obviously, you're going to Google it, right? You're going to pull up an algorithm. You're going to talk to, the first time you diagnose pneumonia as an independent practitioner, I mean, you're going to be like, oh crap, which antibiotic do I use? So understanding that there are guidelines that we teach that you should use. My favorite person to ask, because I trained in MTF, was the infectious disease doctor, because they were always like uber nerdy about this, and I could make my attendees look stupid. But really, there's a lot of things that play into it. There are so many. When I start showing you the list of all the different antibiotics you can use on an inpatient, you'll be like, oh, okay. So it's like, which one don't I pick? That's what you have to figure out. There's so many that you can use. So I'll definitely make sure I clarify what I would like you to shove in your head. Doxycycline. I don't know if I said this at the beginning, but I always have doxycycline on me when I go to the field. It is awesome. Low side effect profile, except if you don't eat when you take it, but I love Doxy. Doxy is one of the ones I always have. Okay. Yep, so there's your list down here at the bottom right. So there's crap tons. There's a lot. This is what I based, this is from Up to Date, I think. So if you're in a clinic and you don't look at my slides, please use a reference like Up to Date. Pull this up. We'll talk to you about treating outpatient pneumonia. Go through your algorithm and come up with a recommendation. Make sure they're not allergic to it, right? So That was one of the weirdest things I learned, came to realize in residency was, like I would ask, I'd come up with something and they're like, okay. I'm like, well, am I right? They're like, well, do you think you're right? I'm like, well, I think I'm right. So there's never one answer for anything. You can do the best answer though. All right, so following up, people in my clinical group probably hate my obsession with follow-ups, but I think that is one of the most important things in providing care. So make sure they have follow-up. You want to schedule it, especially if you're sending them home. Have them come back sooner than later. Pneumonia is not something to be flippant about. Even if it's a nurse visit, just touch base with them. What you want to do is make sure you guess the right antibiotic. And you will know within 48 hours whether or not you guessed the right antibiotic. Because you are guessing. Because if you're not culturing them, you are guessing. It's a really educated guess, and it's probably a really good guess. But these are people that I always do nurse phone calls with. Hey, how are you doing? Are you getting better? If not, I have them come in. Maybe I repeat the chest x-ray. Maybe I need to consider phoning a friend at that point. You can, again, repeat the chest x-ray. You don't have, if they're getting better clinically, you're good to go. Have them come back in a week. This is a picture of resolving pneumonia. It's cool. That's about it. I don't even know. Like if they were getting better, why'd you get it? This is Monday morning quarterback of medicine. All right. So here's the inpatient. This is FYI. I will not expect you to do this because we are training you for outpatient in this course. So, oh, it's an FYI, so nobody cares. Okay, look at this list. Would you like throw up if you pulled that up? Like, okay, go pick an antibiotic. You're like, whoa. I don't even know what this one means, right? I've never even heard of that word. So I want you to feel comfortable with that there's, you know, and people have strong opinions about antibiotics and giving this and giving that, and I think it's silly. I think it's silly. I think you should pick a good one that works. Amoxicillin's good, augmentin's good, fluoroquinolones are good. But every single month, every single day, we find these other reasons, other side effects, this other cost-associated issue. So keep your mind open with it. Don't be afraid to ask. Form your own opinion on this. All right, so nosocomial. This is the other one. This is the one healthcare associated, we call it sometimes. Hospital acquired. There's a ventilator associated. If you go all the way to the bottom, this is what we really care about. We need to think about other bugs. If they've acquired pneumonia in a place where the incidence of Pseudomonas and Staph aureus, especially MRSA, are higher, then we have to change our guess. It's probably still strep pneumo, but we need to change our guess up front. We need to strategize a little bit differently when we're treating these patients because of the higher risk of these bugs, because these bugs can wreak havoc on our pulmonary system pretty quickly. Yep, so there's my little hint. Right, when you're doing your history, when you're doing your little OSCE or your presentation, there's certain things that you don't act. Like, when was your last meal? I don't care, but I do care if it's a GI issue. So when we're evaluating patients and pneumonia is interdifferential, these are things that we have to kind of add on. This is not going to be an OPQRST. It's just one of those unique things that once you start building your patient assessments out of your differential, it helps a lot to say, well, which questions do I need to be asking? What are the important questions I need to be asking? What's pertinent? Well, it's based off your differential. What do you think is going on with the patient? All right. Or wait till you figure out they have pneumonia and then then go back and ask that, right? Like I usually did. All right. So let's see. So this will be a classic, when we have test questions on this, this will be a patient who is in the hospital, who is on day 5 of their ORIC, right? Intrababelos did surgery on them, and it's day 5, and they start to have shortness of breath, and they consult family medicine because they're ortho and they don't know how to treat anything other than, I had to come to Jesus with one of the guys because they wanted to consult us to treat the DVT, and I thought, no, this is too much. That's like your number 1 complication. You can weight-based flow knots. All right. So yeah, this will be the classic presentation. Patients in the hospital recovering from whatever, and all of a sudden they spike a fever. All of a sudden they get a new cough. Daily chest x-rays are going to be part of your orders when you do any inpatient, in some patients, right? This is what you're looking for. Making sure things are resolving, watching for things to pop up, especially in the ICU. Because patients, if they're not awake, they can't tell you. SpO2 might be going down. ABGs might change. You shoot a chest x-ray, you see something evolving, and then you go, well, when were they admitted? Oh, they were admitted like 4 days ago. Okay, this is nosocomial. So we need to start them on something with anti-pseudomonal and anti-MRSA activity. Vitamin B, vitamin P, and there was another one. So we had, when I did inpatient ICU, and we had, when they would, white count would spike, or something would change clinically, we'd always just put them on broad coverage antibiotics. Get that blood culture first. Please get the blood culture first, because the sooner you can get them off of Vanc, the sooner that they can get discharged. And Vanc is, at least when I was training, was not oral. All right, long list of drugs. We'll go over which ones you need to know. This is aspiration. I'm just gonna keep going. Yeah, we're good. Aspiration, you guys can read. So essentially you get the bugs from your GI tract into your airway. I think I aspirate a lot. Those people that when they start choking, right? So the reason alcoholics are more at risk for this is because they vomit and they pass out. So they're aspirating their stomach contents. Oh, hard. Obviously, they're difficult historians. So you have to have a clinical suspicion for this. These patients will come in very, very, very sick. It's a very, very fulminant. So when that bug gets into that airway from those gastric contents, it turns into a very, very severe illness quickly. Klebsiella, Klebsiella cocktail. I still remember that from USMLE 1. Just 2 that go together. It's not the only bug that we see when we have patients who get aspiration pneumonia. It used to be, we said anaerobes were the most common, and recently new studies come out, it's mostly a mixed bag of bacteria. We'll not test you on this, but in addition to causing pneumonia, you can also cause chemical damage to your lungs. ARDS, we'll talk about ARDS at the end of this talk. So high fever. Highest fever I've ever seen in a patient was a homeless guy who had an aspiration pneumonia. 106.1. It was crazy. I was like, this is preposterous. No, it was 106.1 on repeat. Very, very high fever, very, very sick. You have to have that clinical indication, you know, that clinical suspicion. The reason that this is important and why you want to have that clinical suspicion that this might be aspiration is because these patients rapidly decompensate a lot faster than normal pneumonia patients. These are patients that you not have to, but that you should hospitalize. They get abscesses, they get empyemas very quickly. So for some reason, this bacteria introduced into the airway wreaks havoc in the lungs. So if you suspect it, you should almost always admit these patients. get them started on antibiotics. So that's a picture of an abscess. So an abscess is obviously a pocket of infection. Empyemas. You get pus in the chest wall. So ER, direct admit, send them to the ER. You want to make sure that you're culturing them. Depending on what their situation was, they were out in the community versus if they came from a skilled nursing facility or a prison. You have to consider coverage for either cap or nosocomial. Probably need to get O2 to these patients. So again, we just talked about with pants 10 years ago. The key word for aspiration only was anaerobe, but now we know more and it's less common than anaerobe. So we moved away from that. So we do not need to cover for anaerobes for aspiration 1. So we talk about abscesses and empyema. When we see those, they must be drained. So surgical drains are necessary. We used to have to put chest tubes in them. Now we got those cute little pigtail, less, you get less commonly you have to stick a big chest tube out of your side. So we have those little pigtails. That again, you're in the hospital, CT surgeons will come in and put those in for you. We're technically at 52 minutes. You want 5 minutes? No. Yes, please. Go. All right, flu. Flu A and B. Flu sucks. For anyone that's ever had the flu, it is legit. So a lot of people are like, I have the flu. I'm like, you don't have the flu. You don't have the flu. The flu is very severe, high fever. I've never seen someone present without 103.5, lots of body aches. And so if all you can do is moan, you probably have the flu. So very, very severe malaise, myalgias, fever, headaches. We can test. So that's a good thing. You will run rapid flu tests in your clinic at some point. They're very useful. Usually once, like with the RSV, once I've established that there's flu in the community, I kind of stop testing because I know that it's out there. Problem with the flu test is it's got poor sensitivity. Does everybody understand the difference between specificity and sensitivity? So sensitivity means the likelihood that it'll catch it. And specificity means the likelihood that it's specifically that. So poor sensitivity, I'm going to say this totally backwards. So poor sensitivity, it misses a lot. Yes, lots of false negatives. So if you think somebody has a flu and you get a rapid flu test that says negative, is it going to change your management? And that's why I encourage people, it's not one of those tests that, like RSV, is it going to change your management? No. Then why is it important to differentiate? It's not like I guess it's good to capture it for epidemiologic reasons, but. All right, so chest x-ray usually isn't part of it unless you listen and you hear crackles or you hear dullness or patients tachypnic. So it's not necessarily part of the standard, like a foreign body inhalation we talked about. Usually everyone gets a chest x-ray. But if you hear anything on exam other than, air movement in all 4 quadrants and normal vital signs, then you should get a chest x-ray. All right, so majority only requires supportive care. This is one of those kind of like that group where it's going to probably get worse before it gets better, so you need to prepare patients for that. Tamiflu. Tamiflu is advertised really, really, really well. If you read the studies on Tamiflu, it is probably helps, probably won't hurt. So it's not overwhelming that it's this life-saving drug that if you give it to people that it cuts down the mortality, morbidity. A lot of what we see is it just shortens it a little bit, shortens the duration, not necessarily the severity. So that's what most of the studies show. What you need to consider is the longer the person has influenza, the more likely they are to develop pneumonia. So when we're talking about these at-risk populations, then there is some justification to using this to help. So even if it's just that it shortens it, there's still some utility in preventing a secondary pneumonia. And that's about it. So the rules are usually that you, for the general population, that you want to make sure that it is given within 48 hours of symptoms. So if it's somebody that doesn't have any of these comorbidities and it's within 48 hour symptoms, you can start them on it. You can offer it to them. If it's within 48 hours and they have one of these comorbidities, you should recommend it. They don't have to take it, but you should recommend it. And then there's this gray area, right? So at 5 days, almost no efficacy. So there's this 3 to 5 day range where, you know, if you read some studies, and if you read Tamiflu, they said that there is some efficacy up to day 5. That you need to, if someone is going to have benefit from it. So what should you memorize? That's the important question. So you memorize, if a person's otherwise healthy and they just have influenza, you offer it to them. If someone has, as an option, if they have any of these comorbidities, you recommend it to them. And then beyond that, I won't ask any questions on that, but beyond that, use your clinical judgment. If it's day 4 and the person's a poor historian and they're really, really sick and they've already been hospitalized once and they have COPD, right? Or maybe no, not when they have COPD, because you can offer it to them. But yeah, if it's after 48 hours and there's going to be a benefit to it, then I would prescribe it in most cases. But we'll go with the 48 hours of symptoms or recommend with any of these comorbidities. Last one, pertussis, whooping cough. This one keeps making a comeback. So we revaccinate for this fairly consistently. And we didn't really think about it for a while, and then recently we've seen this come back in certain pockets. It came back in Phoenix. You'll see it more. You may see it when you do rotations, but it's come back. So it's something that we need to know about. It's something we need to consider. When you do PEDS rotation, we talked about doing HPI, and we talked about doing history. Asking about child's vaccination status is very important whenever you do an evaluation. So knowing what they've been vaccinated for, because it changes your differential. Not to say someone who's got the vaccine still can't get the disease, we know that, but it changes the ranking of your differential. So make sure you know their vaccination status. So important parts to know about this. So the way we diagnose it is by technically, right? Cough lasting 2 weeks. Otherwise, you're not really sure what's causing it. And then one of these, a paroxysmal cough, an inspiratory whoop, or post-tussive emesis. So it's in the upper respiratory system. So this inspiratory whoop is that classic. So very, very vigorous coughs. So much so, I don't think anyone's ever coughed so much that they've thrown up, but they're very, very vigorous. They're very, very unique when you hear them. That's the diagnostic criteria. Here's the 3 phases. So unfortunately, during that first 1 to 2 weeks, it's non-specific. They're sick. And you go in there and you look in their ears and you do your little physical exam on them and you're like, yeah, I think they have a cold, but their vitals are normal, and here's some Zyrtec, and make sure that you wash your hands and all that good stuff. So nothing very specific. Sometimes you can find eye symptoms. So make sure you're doing a full physical exam, look in their conjunctiva. And this is something Major Klein will go over again as well. This is when they usually come in, when they start that inspiratory whooping sound. So you'll see them about 2 weeks, and then it takes about 3 to 5 weeks until it goes away. So a very, very long course, something we vaccinate for, something that parents usually don't show up for with their kid until around the 2nd week, so they've already been out there in the community giving it out to everyone else. Just to harmony or not. So there's a swab for this one as well. This is one that I would, every case that you consider pertussis, you should swab. This isn't like flu or RSV where once you catch one, you should definitely swab these. These are reportable. But even that, if you can't, you can still make the diagnosis. Supportive care. Make sure that you're hydrating them. You need to treat these. So this is something that you need to prescribe for. Macrolide. I know I was like, as if Z-Packs or get poo-pooed a lot, but this has been the medication of choice for a long time. So something that I would probably ask you because this is how we treat it. Admission criteria, similar to what we've talked about, a very, very young, they're working hard to breathe, you might need to support their breathing, you might need to support their eating. And the last thing that's kind of unique to pertussis is you need to treat contacts. And I'm going to just tell you what you need to know on this later because I'm tired today. 3:30.